whether it's in the ICU, whether it's on the floor, whether it's in the operating room, and all the different notes they have to write, transfer orders when you're moving a patient either into the hospital or from one section of the hospital to the other, and then finally the discharge summary of when the patient has to go home. Long story short, this is the bread and butter of our jobs as being a physician assistant, is documentation. It's everything that the docs don't want to do that has to be done by Medicare guidelines and hospital guidelines. So it's many people just, sometimes they moonlight and they only do H&Ps and discharge summaries for different hospitals. They'll come in on a weekend, they've never seen the patient before, but it's all paperwork, it's all documentation. And this is going to be important not only for you to know, but you're going to be actually doing this as part of your surgical OSLR, which we'll talk about a little bit at the end. So, the bread and butter of what you had a whole course happy on is the history and physical exam. When a patient comes in to the hospital, whether it's for a medical reason, pneumonia or so, or whether it's for a surgical procedure that they're coming in, an elective procedure that they'll be there for a few days and then go home, or maybe even go home that same day, you must have a history and physical exam. And you can just take a couple notes, don't feel like you have to pull up the PDF on there. But I will tell you, and I'll read this word for word, on the first page of the document at the bottom, which is page 143, where it talks about admitting a patient to the hospital. I'm just going to read this paragraph here, and I'll tell you what's most important for you to know. So, according to the JNC, the Joint Commission, and the Medicaid and Medicaid services, they list a few things that must be done. And the first one here says the author of each entry must be identified. And you don't have to type this, but I'm just going to say this is the area right here you can highlight, and make sure you read this 3 times over, so you don't have to type any of this. But on the first page, I'm just going to read this section right here. All records must document the following as appropriate. Evidence of a physical exam including a health history performed no more than 7 days prior to admission or within 48 hours after admission. Very important to know. And some hospitals even push that where it's only 24 hours after. But the important thing is it can't be done more than 7 days prior. So if you go see a consultant, you see an orthopedic surgeon in the clinic for a problem X, and he is able to pull up in the hospital someone else did a history on the patient, history and physical exam 4 days ago for, I don't know, maybe they were admitted for a toenail or something, whatever. Technically, they could use that. That's a history and physical as long as it was done within the 7 days prior to that hospital admission. If there's not one done before 7 days, then one has to be done. And that's where we fall into doing that. It talks a little bit more about admitting diagnoses have to be there, and any consultations and documentations of infections and complications. You can read all that yourself. For those of you who just walked in, I'm just talking about the PDF on the second column of page number 1 that you do need to know. So this is the document that I basically gave you on Moodle that I showed you on the day 1 that you will be doing as a surgical OSLR, and we already reviewed it once. But we're going to be focusing a little bit more in this 5th quarter on the differential diagnosis. So after you see the patient for your OSLR and you do everything, before you get your labs, as soon as you're done doing the physical exam, our question is going to be, and we need you to list X amount number of differential diagnoses before you get the labs. Okay, so we want to know what your thought process is. Then you're going to get your labs, your special tests, whatever you need to do to help figure that out. And then you'll have more information to kind of narrow or additional questions you can ask at that time. So after that, and you've already done these before, and we've talked about it, you'll fine tune it a little bit more in the surgical OSLR. Then what do you need to do? As a PA, you're going to be writing orders. You're going to be writing a ton of orders in the hospital. Obviously, when they first come in, you're going to be doing admitting orders. Let's say you admit the hospital for an operation and they go to the operating room for their gallbladder. Then afterwards, you're going to be writing a new set of orders called transfer orders or post-op orders. Okay? Every time a patient goes from one section of the hospital to another section, a new order set has to be done. It doesn't matter where they go. If you take a patient From the operating room to the ICU, that's one set of orders. If you go from the ICU to the floor, that's another set of orders. So anytime you transfer a patient anywhere, you have to have a new order set. We'll go through what you need to write in the order set, but just be aware you're going to be writing these orders a lot. And some of it's very redundant. You're like, why can't they just cut and paste them? And sometimes they can, and sometimes they can't. Different institutions are different, but for the most part, you have to keep in the back of your mind that you must rewrite all the orders, which is a pain in the butt, but yet that's the bread and butter of what we have jobs for. So maybe a patient comes in and they have a pneumonia. So you admit the patient to the hospital for pneumonia, you write your admitting orders. They're in the hospital for a day or two, they get a CT scan, they get a chest x-ray, they get antibiotics, and come to find out now the patient has an empyema. The CT scan comes back and there's an empyema. All right, so now a surgical consultation is placed, and the cardiothoracic surgeon, or if you're the team, you go there, you see the patient, and then you're going to write perioperative orders if you're going to then take the patient to the operating room a day or two later to do a VATS procedure with a decortication. So order sets can be done by different groups at different times depending on what needs to be done. Those could be perioperative orders. So maybe the CT surgery team comes in and they're going to say, okay, we're going to take you in a day or two to the OR. We'll write some orders what we want done between now and then. So they go to the operating room, they have this procedure done. Afterwards, you're going to be writing post-op orders of what you want the patient to have or not have when they go to the recovery unit or the ICU. And they're there for a day or two, and then they transfer to the floor, kind of the step-down unit. And guess what? You're writing another set of orders from there to go to whatever unit they're going to go to. And then at the end of everything, we'll talk about the discharge summary coming up. Now, there's a couple ways to try to remember the order set. And I'm going to tell you the way that I learned it. I'm just going to ask everyone to follow one order set. And your PDF that you have there, the second important thing I want you to look at, besides that page number 1, column 2, is this section called admit orders. Okay, and it's going to explain a little more in depth everything that I'm going to tell you right now. And there's a silly mnemonic up here called ADC Van Dismal. There's 2 A's in there to remember. ADC Van Dismal. And if you can remember that, you can write any order you want for the rest of your life. Okay, people are going to tweak it, people are going to move things around, they have different mnemonics to help you remember these. But ADC Van Dismal is what I want you to remember. So let's talk about A. What is A? A stands for admit. If you do have that PDF there, that's the same A there. So admit. Where are you going to admit the patient to? If this is the first time, you're going to say, admit the patient to 6 West under Dr. Smith's care. So it's not only a physical place, but it's the who is going to be also in charge. There's always one attending that is in charge of the patient when you admit the patient, who accepts the patient. It might be the hospitalist, it might be the consultant, if it's an orthopedic surgeon who's going to plan to do the surgery the next day, but there's always one person. And that's important to know because when you do your discharge summary, one of the topics is who was the admitting the admitting physician or surgeon. So it's a kind of 2 steps of that, where as well as who that you need to know there. Then the second letter is D, which stands for diagnosis. And I'm just reading right from the PDF as well. Your diagnosis is the main reason why they're being admitted. You may not always know the diagnosis. So let's say a patient is just being admitted for shortness of breath. You don't know that the cause could be pulmonary embolism, or you don't know for sure that it's a pneumonia cause. But if you have an idea of what it is, then you should put the diagnosis. So let's say you got an ultrasound in the clinic and you found a DVT and they're severely short of breath and their pulse ox is down to 89 and they're worried and they're anxious, then you list the specifics that you have. So diagnosis could then be shortness of breath, positive DVT, suspect pulmonary embolism. It's not so much a black and white thing in the beginning, because that's why they're in the hospital, to figure out what the main problem is. If it was a patient coming in for CABG, and sometimes they are elective, or they're found out, and then we plan surgery a week later, so you would say the main diagnosis why they're there would be coronary artery disease, the main reason. Diagnosis. So C stands for condition. Your condition of the patient is simple words like, you've heard this on the radio when they talk about VIPs that go to different hospitals for procedures, maybe it's a president or so, and then they want to know, is the patient in stable condition, are they in critical condition, are they in guarded condition? There's a list of these 6 or 7 words to be aware of: morbid, comatose. You'll notice that in the PDF. After you do ADC, then there's VAN, V-A-A-N. And the V stands for vital signs. Your vitals. Now, you have to be very specific here. It's not just vital signs, every 3 hours, because vital signs mean different things in different places. If you want a temperature, blood pressure, pulse ox, you have to be a little more specific. You have to say not only when you want it, but clarify it. So if you write vital signs and you write out everything you want every 4 hours, that technically means they'll wake up the patient at midnight, at 4 in the morning, every 4 hours around the clock. Versus if you say vital signs Q4 hours while awake, then they're only going to they'll allow the patient to sleep at night, and when they wake up, then they'll do the vitals there. So it's something to think about, because it's easy to forget, and then they start waking them up, and the patient's crabby the next day, and they're not going to be very happy in the hospital if they're woken up every night. Sometimes we have to. Sometimes there's continuous monitoring that has to be done, and different catheters and things can be getting your arterial blood pressure, but you still need to wake them up to do manual blood pressures in the lower extremity, so you have to just write out everything specific where you want it. Some of the more common ones, vital signs, Q8 hours while awake, Q4 hours. Something else besides the 6 vital signs that we've already talked about in previous classes that you do need to know. Remember, there's 2 parts to each of those. So the temperature, the pulse, the blood pressure, and that's what's going to be very important for this surgical hospital, that you know there are 2 parts and you're following each of those. Is going to be the daily weight. For some specialties, that's not very important. For others, it's extremely important. If you're trying to see not only what the I's and O's are of how much they're intaking, drinking, and how much they're peeing out every day with output, but another factor to put into this is their daily weight. And this daily weights, at least in cardiac and cardiac surgery, are extremely important. But there's 2 types of weights if you've never seen in the hospital. There's the bed weight, that in the ICU, if you can imagine a patient's on ECMO and they have all these catheters coming in and out of them, and you can't get them out of bed even if you wanted to. The bed can weigh the patient, and they try to compensate for some of the tubes or that, or the minute they land, they know what at least the initial weight is on the bed, and every day they can kind of get a rough estimate of that. But you add a lot of dressings and a lot of padding and things, and that can quickly give you a false reading pretty quick. But the best way to do is really the standing weight, is where they will wheel in the scale, basically, and sometimes there's a standing scale where they can hold on to it, and they just get on the scale and they can see the number there. So that's really the best thing you can do, and our job is to get patients out of bed sooner anyways. So people hate to wake the nursing and the CNAs early in the morning to get them out of bed, but it's very important. If you're doing your rounds at 6:30, you kind of need that data to determine what LASIK orders you're going to be writing for the day. Because you have to be in the operating room at 7:30, and you're not going to get out for about 6 hours. So you're hoping that those orders all get taken care of. So sometimes planning is very important with that. So don't forget about daily weights with your vital signs. And then the A's, there's two A's. The first one is allergies. Very simple. Two parts of this, not only what the allergy is, but what is the reaction that they've had to it. So two parts to the allergies, remember. And the next A is activity. So it's the activity of the patient. Are they going to be up at lib whenever they want? Are they just coming in for, a day before they have an operation and they're just like you or I right now, so they can walk around? Or are they bed rest? When you see the PDF, you'll go through, there's about 5 or 6 different things, and I'll read them off. Bed rest with bathroom privileges, when they can go on their own. Or maybe it's bathroom privileges with assist. That means the CNA or the nurse would have to escort them if you're worried about a fall or so. Non-weight bearing could be put in there if it's an orthopedic complaint or they've had an injury. Ambulate with assistance. And I can even tell you at Mayo Clinic, I'm not sure how it is at UT, but sometimes around the holidays, they have lots of restaurants right outside of Mayo Clinic, and their families will come in for Thanksgiving or Christmas common, and they want to go across the street to have dinner at the restaurant. And literally, I'm not joking, sometimes with like IV vancomycin drips going, because people can go home on vancomycin drips too when they need them, right? So it's kind of ironic, and all the restaurants around there kind of know of this, and it's very frequent. So the families will come in, 5 or 6 family members, they want to take, grandma across the street for a turkey dinner, and you're walking across with the IV pole, if it's approved, and everything else is, they're just doing well otherwise. And yeah, you can write that, but a specific order has to be for that. Or sometimes the nurse will call you and they say, hey, the patient wants to go off the floor, maybe they want to go to the chapel, maybe they want to go here or there. You have to write a specific order for that, and you may plan for that in advance, or it might be that day when the nurse calls you and asks for that kind of special order. So that's going to be your activities. And then VAN, the N stands for nursing. So there's a lot of things. Basically, any kind of care that I think is given to the patient is what you're going to be putting in this section. So maybe it is specific nursing things. Maybe it's wound care instructions, as an example. Maybe you want the dressing change Q12 hours, right? You have to be specific. You have to write that out. Maybe it is special therapies or so that you need them to do, whether it's ambulation or getting out of bed or walking the halls. Sometimes specific, any instructions that you want nursing to do for them. Incentive spirometry. We've talked about this a little bit with the 5 W's and when atelectasis. This is where you would put that in there. It may not necessarily be a nurse that's doing it, but I think of it as a specific order that's unique for that patient. So incentive spirometry, Q4 hours. And just remember, it's not blowing. You're not trying to blow a balloon up when they have this device. It's actually sucking. It's trying to suck in to open up their airways to prevent the atelectasis. So remember that. It can be specifics regarding chest tubes. We heard a little bit about chest tubes the other day. If a patient has a chest tube, the chest tube is hooked up to a canister. That canister was technically to gravity, right? If there's anything that comes out of that patient, it would go to gravity and get collected in that chest tube, in that container. Well, let's say the chest tube is really in the chest, and you're worried about a pneumothorax that they have, and you're trying to clear it out. Well, now there's actually a little section inside that canister that has a tiny little bit of water in there. I forget, about 100 cc's or so, blue water. They put a little blue dye in it, so it's very bright blue. It's kind of a teal blue color. And in that situation, not only would it be collecting any fluid, and you measure that, how much blood or drainage is coming from there, but also this little pocket of fluid that's in a separate, it's in the entire canister, but it's in a separate component of that, is where you would look to see if there is still air coming out of the chest. And to do that, you look at that little blue water area, and you'll see if little bubbles are coming up. If you see bubbles are coming up, it's one of two things. Number one, there truly is air that's leaking out of the lung that is going through that tube, and you see it, the little bubbles that are coming up. Or, what else could it be? What'd you say? Loose connection, absolutely. So why that becomes important is we, as the PA, have to investigate that to make sure. I have found cracks in the tubing before, no different than a crack in your air hose or so in your own car or vacuum cleaner or something that could happen. Or the connections are not stuck as well, as tight as they could be, and there's some air that's going through that tube. It's not really a crack in the tube, but it's just kind of loose over there. Or it's fallen off. I found, you find that too, the connection, little piece there. Or the other area that you have to trace it all the way back. So from the canister, at every point along there, whether it's two tubes coming together with the connector, or all the way back to the patient, where you take the dressing off, and maybe there's a big gaping space that wasn't tied off very well, and now air is being sucked into the chest from around the chest tube. So that's how you can sometimes get air into the chest that way, and then it leaks out. How would you fix that if you could?
Piece of petrolatum gauze.
What'd you say?
Petrolatum gauze.
Yes. So Vaseline gauze basically is one way you can help that. And literally, you open up 4 or 5 packs of Vaseline gauze if you're concerned about it, and you put it all around that area. You pack it in nice and tight. You put some 4x4s around that. Put a nice, what we would say, occlusive dressing around there. So the tape that you would put would be a special kind of tape, not the paper tape, but the good stuff, the foam tape that I don't know if you've seen any of that stuff, but it works really good. And literally, you're gonna tape it really well to prevent that. But let's say your hospital's out of Vaseline gauze. You can make Vaseline gauze. The old-fashioned way 100 years ago is literally they would get sterile gauze and Vaseline, petroleum, and then make gauze and do it. But now they charge money for that, so you can open up the package of that. I saw you made the maneuvers over there, Nick. What is it?
Just throw a stitch.
Throw a stitch in there. So it's not uncommon that you find a gaping wound. Maybe they had a stitch and it broke off, it loosened up. Now you can put another stitch in there to kind of put some lidocaine in there and close it up. So that's a very important thing that we need to do. But writing the orders for chest tube to suction, well, let me say chest tube to water seal. Those words, chest tube to water seal, means to gravity, basically. So when you look at that blue water component inside the canister, you're seeing if there are any bubbles, and that just means there's no suction to it. Chest tube to water seal, that's what the wording would be. Versus chest tube to suction, now you've actually applied some suction from the wall to that canister to actively pull out any of that possible air that could be in the chest. Many times after open heart surgery, we always do chest tube to suction because there's some blood and we actively want to get any of that blood out because we don't want it to form clots, which could form tamponade or so around the heart or the chest or whatever, so we actively want to suck it out. But after a day or so of suction, we may change the order from chest tube to suction to now chest tube to water seal to see how much drainage they have making on their own. So suction will actively pull, but what happens is if they're making fluid, it actually, if you're continuing to suck and you're almost making the pleura make more and more fluid because it's sucking it out. So what you want to do is put it to water seal to act as if how much are they normally making on their own and how much is coming out. It's not uncommon when patients stand up, if they've been lying in bed, if you walk in the room, they may have a pocket of 600 cc's of fluid in the pleural space that the chest tube hasn't had time to drain out because they haven't stood up. So often the nice thing of standing up with doing a weight in the morning is that they will dump, what we say, any of that fluid that's been sitting there overnight in case it was like a pocket and the chest tube was more anterior and the fluid is more posterior. So moving the patient around or getting them to stand up is actually kind of a good thing. You need to document those dumps because we're worried about, is it a big amount of fluid that's very bloody, that you're worried about a new bleed that has occurred? Or is it more of a serous yellow drainage that's pretty common and normal, whether it's pleural fluid or you do some pericardial fluid after a while? So chest tubes would be part of that. Your I's and O's of that, how often you want them to measure, how much they're intaking and how much they're losing out. How can, what's the breakdown of some of the I's and O's for some of you who have worked in a hospital with patients? How would the nurse document their I's and O's?
Urine output?
Urine output is one of the O's, absolutely. How much urine, so that's important. Now, if they're getting up out of bed on their own, how are they going to record that? Yeah, so they're gonna put some sort of a container in the toilet, so when they pee or that, then the nurse will come in and just kind of, gauge it and dump it out and has to record it there, right? So the problem is if patients are peeing on their own, they're getting out of bed on the floor, and they're not recording it, then sometimes the O's are falsely low, even though they've been urinating, so you gotta just ask the patient, how many times did you pee, yesterday or so, just to double check it. What other kind of O's are there? If you started with the O's, let's start with the O's.
Drainage.
So you got drainage, right? That chest tube drainage is part of the O's, and that could be, 500 cc's, it could be 2 liters. The first 24 hours in a big operation, that has to be part of that, yes. What else? What else? What other tubes? What? Suction, I heard suction. How about up here? Nasal gastric suction, NG tube. So if someone is bleeding, upper GI bleed, there might be, a liter or so gastric contents with blood. Basically anything that exits the body. Even wound drainage, wounds that are very copious, infectious disease might come in and say there was, 250 cc's of drainage in the past 24 hours. That's quite a bit, right? They're changing the dressing every hour, but that's still a fluid component that is leaving the patient. So nonetheless, there are subtypes of the O's, which all come together and must get added for the total output. How about your N's? How do people get fluids into them? IV fluids, very common. That's a nice, easy way you can calculate. If they're getting 100 cc's an hour or 125 cc's an hour, you calculate it out. Nursing does that. It'll come up. Sure. Question? It includes what? Well, it can be if it's diarrhea, absolutely. I mean, if it's hard formed stools, we don't really classify that as the O's, but any diarrhea, absolutely. If there's water, yes. That's very important to know. So any kind of fluid that's in or out from any orifice or any body part. Yeah. Sometimes people have different drains in different areas. You have Blake drains and JP drains, and you'll talk a little bit about that, and you have to add up all of those together. But diarrhea, absolutely. So I's, you mentioned the IV fluids, okay? How about oral intake of fluid? So if you're allowing patients to have so many cc's of water or Gatorade, or maybe you're gonna put them on a fluid restriction, so they can only have so many fluids, you only want them to have 500 cc's of water a day, then you literally have to, the nursing is gonna watch that and give them a small amount. People get fluids from other, like coffee and that. They love their coffee in the morning in the hospital, so they have to calculate all that. Maybe it is even by NG, you got some fluids going in there. How about blood, right? Transfusions, that's gonna be that's a fluid amount that can be calculated, that's going in. What else? Anything else?
TPN.
Bladder irrigation. Dr. Smith, would you say nursing would classify that as an N? I don't.
What they would do if they're on a floor that they're used to doing it, typically they are, is they take the irrigation and they will subtract the output. They'll put the output from the Foley, then they'll
What I've seen it for is more like a procedure where they put so much in and so much comes out, and like you said, the difference would be yeah, the difference is more important than the actual
If
total.
you're gonna have a patient on the floor where they're not used to doing it, you may have to wipe that order.
So basically, any fluids that are going in and out of the patient must be recorded. And at the end, we'll talk about the progress notes. You need to record what are the total I's and O's. And then you can break that down by chest tubes, and we'll give you some examples of that in just a few minutes. So oxygen is another nursing thing, how much oxygen you want to give the patient. 2 liters by nasal cannula, or non-air breather, 10, or whatever it is, any kind of issues there. We talked about chest tube, water seal versus suction. That's going to be important. The last thing I just want to talk about chest tube that you may see in certain areas. Certain surgeons like to clamp the chest tube. What I mean is right before, to make sure, before you pull that chest tube out of the patient, that you're not going to have to put another chest tube in, just to be safe. Sometimes what we've done is we've clamped the chest tube. You wait 8 hours, and then you get a chest x-ray just to make sure that they're not filling up with fluid or there's not a pneumothorax that's increasing there. Now that's not standard. Most of the time, old school, you just pull it, and you've known how much fluid has been coming out. You know if there's a air leak or not from the chest. And most of the time, after a day or 2 or 3 days, you just pull it out. But you may run into that where the surgeon will say, hey, clamp the chest tube. And what that means is they probably want a chest x-ray 8 hours later and just double check it to make sure there's not any rate accumulation. So clamping the chest tube is almost like having the chest tube out of the body, if you think of it that way. And then they know for sure that when you pull it, they feel more safe with that there. At some point later in the course, remind me about chest tubes and talking about when we pull them and how to pull them and how to close up the holes in that, but that's not for this lecture. We'll talk about that again. Maybe it's breathing treatment as part of the nursing where you want to add some nebulizers besides the incentive spirometry to help them open up their airways. That's something that could be considered more of a medication, but also I've seen people write as an order side. It doesn't matter where you write all of this as long as it's all in there, but I have seen people write that there. So any special devices that they would need, if they have to walk with a cane or walk with or what type of a cane. There's all these different types of names. Some have wheels, some don't have wheels, some have 2 wheels in the front, some have 4 wheels, and different things that you've probably seen in the nursing home as you're going around looking at some of that. Any kind of the breathing thing is kind of important with incentive spirometry. Just want to reiterate that one more time. There's a couple other things listed here on in your document to look at also. So after the nursing, then you're going to get into DISML. And the D stands for diet, what their diet is going to be. It may be nothing by mouth, NPO, right? If you're going to go for an operation in the next 12 hours, you want to keep them NPO. Maybe you're going to allow them to have some clear liquids now for a certain amount of time. You have to be specific and spell all that out. Maybe they're going to be on a special type of diet, like a diabetic diet, 1,800 calorie or whatever specific you want. Low sodium cardiac diet, commonly written order, set after patients are admitted with heart failure. There. There's a few different diets, but focusing on when they need to be NPO for any procedure is going to be important. Sometimes medications need food to be taken with it, and sometimes not. So there's lots of thought process that has to go into that, and you're changing this sometimes on a daily basis when they need it. I stands for IVs, IV fluid. What are the more common ones that you've already read about and you've heard about?
Normal saline, lactated.
Normal saline, lactated ringers, D5 half normal saline, D5W, some of those ones that you saw in that PowerPoint, I think 2 weeks ago. You probably heard a little bit of them in emergency medicine, and you'll continue to hear about them in the surgery course. So how much generally are you going to give a patient, an adult patient, IV fluids if they're NPO? You have to think about how are their kidneys doing, how is their heart doing. You don't want to fluid overload a patient if they can't handle it. You don't want to dehydrate a patient too bad, so you have to find the balance, and there's a couple different calculations. Dr. Smith is going to be doing some trauma cases with you in a couple weeks, and she's going to be going over a lot of that for the normal patient as well as the abnormal patient. So, long story short, and I shouldn't say this out loud in front of Dr. Smith, but I've read in many books they say a normal patient who has a normal heart and normal kidneys, 125 cc's an hour, is they say either 100 to 125. It depends if you want to tank them up a little bit or not. But if someone's not having any, you breathe off, I forget how much it is, anywhere from, I won't even say the number, but anyways, we breathe off a lot of fluid each and every moment, every day, and we're chronically dehydrated, many of us. So if they're NPO and they're going to undergo a big procedure, 100 cc's at a minimum. Some could even, if you want to be more conservative, give 75 cc's an hour. But somewhere in that range of 75 to 125 is kind of the one number you can keep in the back of your mind for a normal patient, and then modify it from there. So I think that's a nice, good rule of thumb. Okay, so ADC, VAN, DIS, ML. There's only 3 left. So the S stands for the special test or special instructions that they're going to have to do. Special tests or special instructions. So maybe you want to get that CT scan in the morning with contrast. Maybe you want to get an ultrasound on the patient. Maybe you want to get some special therapies like physical therapy consulted or occupational therapy consulted. Or if it's a stroke patient, maybe speech therapy for the patient. So any kind of special instructions, special consultations, special therapies that you need is what, this is the area that I think about writing that stuff. And they talk about that as well in your book there. M, question?
So, in the I's and O's under nursing, we list the IV fluid, how much is given, but then we also list again the IV fluid.
No, IV fluids is how much the patient is currently, what the order is that you want them to have at that time. So when they're admitting into the hospital and you write this ADC Van Dismal as the admitting orders, they're going to say, okay, patient's NPO, I want you to start normal saline at 75 cc's an hour. That's the order. That's what the nurse is going to, the order they're going to follow. They're going to get the saline, they're going to hook up the IV, they're going to give them that amount. What I'm saying with the I's and O's are in the nursing order. It's not that you're recording, it's any specific things of the chest tube. So the chest tube, is it to water seal? Is it to suction? That would be one of the O's to think about. The urine, you're writing the order to record it, every 8 hours, or Foley catheter. Specifics, is it to gravity? Basically, it's what you want them to do. Orders are, you're telling somebody else what they need to do for the patient. That's what this entire order set is for. It's not recording that. That's going to be the what we'll talk about in a few minutes with the progress note. But this is what you want others to do for the patient. You're the prescriber here.
The other question I had was, you mentioned under nursing about like canes and wheelchairs, things like that. Is that also an activity, or?
Yeah, that could be put in activity as well. So if you want to say ambulate, with the cane or wheelchair, people put it in different areas. I don't care as long as the specifics are in there somewhere. This is what I want you to remember. This is what I want you to follow. If you can remember that, it'll help you if you choose to put that stuff more with the activity versus in the nursing. That no one's going to care about that. So now we have 2 left, M and L. M is for medications and L is for labs. Medications will include any and all medications that you want for the patient. They may include some of their admitting medications. Maybe they were on an antihypertensive and you want to continue that in the hospital, metoprolol, 50 milligrams PO BID. Very specific. You're writing the name of the medicine, generic names. You're writing the dose of the medicine, how they need to take it, whether it's oral, rectal, subcutaneous, intramuscular, whatever the route is, and then how often. So maybe it's daily, maybe it's QHS, maybe it's BID, maybe it's TID. Now TID is different than Q8 hours. If you've never heard this before in pharmacology, Q8 hours literally means every 8 hours they get the medicine. TID just means 3 times during the day they get that medicine. So they could choose to take it at maybe at breakfast and lunch, and then maybe they're going to take that third one right before they go to bed. So there could be almost a 12-hour difference between the second and the third dose if they want. That's what technically TID means. We try to say, roughly take it equally throughout the day, but that's not what TID means. TID just means 3 times during the day, whenever is fine. QID, same thing, 4 times during the day. If you want to be specific, you say Q6 hours, you say Q8 hours in your order set for that. So again, the generic name, the dose of the medicine, the route of how they're going to be taking it, and how often they're going to be taking it. Now, I'm okay with your write-ups if you do QD, for daily, or you write the word daily, BID, TID, Q8 hours, Q6 hours. I'm all right with that, but I can tell you in the hospital, they've gotten away from those abbreviations, and they don't like QD anymore. It must be written out daily, right? Okay, so you know what? No QD in your write-up, we'll just say daily. Just write QD equals daily, but I want you to all understand that QD means daily. So just write the word daily in your notes, as per Dr. Smith, just so it's a good remembrance for everybody in their lifetime. Yeah.
You won't be doing hardly any handwriting anymore. It's almost all computer. 90% of my so it'll be computer generated. But if you have a handwritten, apparently QID and QD has been
Too close
used
together.
enough times because of bad handwriting that it's no longer allowed. My JCHO, big, organization that's all.
And then there's a QOD as well.
Yes.
Every other day, QOD, QID, QD. So they kind of got away from that, even though we've done that for 100 years or longer, probably 500 years. But it's good that you're aware of it in medicine, because you'll notice a lot of docs who, if you're writing prescriptions and you're not doing electronic medical records, depending on where you live in the country, you're going to see the docs writing the prescriptions. Pharmacists all know this when they get those. You may be writing them out that way. When I came from Wisconsin and La Crosse, the free clinic that I worked at, we just hand wrote all of our prescriptions old school on pads, and I could get away with writing QD, QID, and BID, and the pharmacists still all know that, so you have to be aware of both of those. So what types of medications, besides their admitting medicines that you may want to or may not want to continue them on, what kind of medications are going to be important to think about in the hospital?
DVT prophylaxis.
Would you say? Antiplatelet therapy, which could include what? Warfarin is not antiplatelet at all, but aspirin mainly I think about, clopidogrel, those are possible ones that they may need to be on, so yes. What else? Well, or, you already said warfarin, but let's talk about that. The anticoagulants, right? Things like heparin, things like Coumadin, if you're going to be putting those on, sure. Any kind of anticoagulants or antiplatelet therapy, sure. What else? Analgesia, another A there, so pain, right? Most patients are going to have some discomfort, whether they're undergoing a surgical procedure or they have a chest tube in them, maybe for an empyema. That's just, it's discomforting. Now, there may be a specific amount you're writing on a routine basis. Maybe it's going to be a drip that they have that you're writing. There's all protocols for that, but kind of order sets for that. Or maybe you're going to write some PRN medicine every once in a while. What kind of PRN medicine do you want to write?
Pain meds.
What kind of pain meds?
Morphine.
Morphine. How much morphine do you want to give them?
2 milligrams.
2. All right.
Every 2 hours.
Every 2 hours. He wants two Q2. You can do that, sure.
I'm good.
1 or 2 milligrams is going to be fine for some patients, and there are a lot of people who are taking opioids and other drugs where 2 is not even a drop of anything. So you have to figure out what works for different people. Always start low and gradually go up if needed. The PCAs are pretty awesome nowadays. You can do a pain service consult, depending on where you are in certain hospitals, and they will come and they will literally run that for you so you can medically take care of the patient. That might be a special consultation you want to put in for certain patients, pain consult that we would have at the hospital. Okay, so you got your pain, your analgesia. Maybe you just want to be nice. And what's if you're not going to do IV stuff, orals? What kind of oral pills would you want to give for pain? What's the minimum you would give them? Tylenol, generally speaking. Don't forget, third world countries are grateful to get any Tylenol. They don't have Tylenol. That's all they have for surgical procedures. Hard to believe. But what's the next step up if you want to think of something to give them? Given that their kidneys and everything else is fine in their body.
Toradol.
Percocet, they go right for the Percocet over here. So I heard Toradol. Toradol is a nice option. What does Toradol come in? What's the dosing? You can give 15, you can give 30, 45, you can give 60. So in 15s, I think about 15s. Usually 30 and 60 is what we usually write for. But Toradol, yeah.
Tramadol?
What is one condition, I'll give you a clue, it's a lung condition, that you would not want to use Toradol for post-operatively?
Atelectasis.
And I made this, no, it's not atelectasis. No. And I made this mistake, Dr. Smith, I'll never forget. We did a lung case. I wrote for Toradol because I had heard that the surgeon, for all his lung cases, he uses Toradol. You know, you can't use Toradol for cardiac cases. We'll talk about that in a second. But you use Toradol for all the lung cases. So I'm a new green PA, a year on the job, and I write for Toradol. I'm so happy for myself, I remembered it. And the next day I come in and the surgeon chews me out for writing Toradol on this thoracic case. What do you think the case might be? Any ideas?
Is it abscess?
We did a pleurodesis. So what I mean is the patient had a lot of fluid coming out. We went to the OR, we sucked out all the fluid, we introduced some talc or doxycycline or whatever it was to get these 2 layers to stick together, right? The visceral and the parietal pleura, to prevent any kind of space there, right? And what did I write? I wrote the anti-inflammatory of Toradol, right? We purposely want an inflammatory reaction to occur between these 2 spaces. And I came in the next day and got chewed out, but I never forgot that from that day forward. And we all learn more from our mistakes than anything, so.
I want to just bring up one other thing too. Orthopedics, they don't like to have a cow, you like Toradol because the first phase of bone healing is inflammation. So, and right now, I think there's been studies announced in our hospital, we can't write over 15 milligrams because there's been recent studies showing 15 milligrams is good at 30, but you might be able to do it at other hospitals. Don't be surprised if you're restricted for the elderly. I think they're now recommending 7 to 5. So there's been a couple changes just in the last year.
Why don't you want to use Toradol for cardiac cases? So,
NSAIDs are contraindicated.
specifically coronary artery disease cases. Anyone with coronary artery disease?
You don't use NSAIDs?
NSAIDs, not good. NSAIDs generally not good coronary disease overall. There's another medicine besides NSAIDs that is technically contraindicated with severe coronary artery disease. And just yesterday, I gave your bigs a kind of a mini quiz, as they're getting ready to graduate there. And I put that, I said, which headache medication is contraindicated in severe coronary artery disease ischemic patients?
Imitrex.
And you know what, 50% of them did not know it. And that's okay, but I'm glad that they did then know it because they may see that question 60 days from now when they take their board. Does anyone know what that is?
Imitrex?
Imitrex, any of the triptans, sumatriptans, any of those. People may or may not know that, but the headache medicines of Imitrex and that whole family is technically contraindicated only in coronary artery disease. So if you did a valve replacement, you could use that, that's not a problem, but if it's coronaries, that's important to know. So yeah, NSAIDs, higher risk of myocardial infarction afterwards, so aspirin good, NSAIDs bad for coronary artery disease afterwards. So something to talk about some of your patients with. So you talk about some analgesia, right? Oh, Toradol. And then there's another thing, Ultram, that you can use. Sometimes it's helpful. It's kind of a step up, I think, of Tylenol. So I go Tylenol to Ultram, which is called Tramadol. The generic name of that is Tramadol, that you heard about in pharmacology somewhere. And then your Toradols, as long as there's no contraindications of them. And then you get into your opioids that you need. And a little bit of morphine from time to time is fine to take the edge off. Okay, so what else? What other meds? You got antiplatelets, analgesics, what else? Antibiotics, another one, very good. Now the antibiotics have to be followed on a daily basis, or it has to be written for a specific number. So if you're gonna write, while the chest tubes are in, you're gonna write some Ansef, Cefazolin, every 8 hours, then you better write for either how many doses you want, or how many days, or use write until chest tubes out. You can be more specific in your order set there. If you just write Ansef, 1 gram Q8 hours, and then you pull the chest tubes 2 days later, they're going to continue to give that Ansef until somebody picks up on it, and you actually have to DC that order. So you have to think about it while you're writing the order of how long do I want this? Is there a reason that I'm writing it? Is it because there's a chest tube in, and then I'm going to pull it out afterwards as soon as it's stop the order when it's done. So good, antibiotics.
So if you write it until chest tube is out, you don't have to DC that order on.
Well,
Yeah.
theoretically you don't have to, but every hospital is different. So all I want you to do is at least think about it. And they may make you on a daily basis go through the orders and the medication orders. So it depends where you are. Good question. What else? What other kinds of meds would you want to use for patients?
Antiemetics.
Antiemetics. Great. So lots of people have nausea, vomiting. Maybe anesthesia is taking care of this for you as part of their protocol, and maybe they're not. But it is something you need to think about. What do you want to give them?
Zofran.
Zofran. Everyone says Zofran, right? What's the generic name for Zofran? Ondansetron, right? The O word. Remember that? Well, that's okay, but we didn't have Zofran for a long, long time. So there's another 10 other drugs that you could use, right? That we kind of forget about. Phenergan, sometimes people like to use. What do you like to use, Dr. Smith?
Yeah, I'm a big Phenergan user, but even Reglan.
Reglan. What's the other name for Reglan? Metoclopramide. Yep, gotta remember that. Metoclopramide, Reglan. That helps move everything in a forward fashion so it's not getting backed up, so they're not feeling that fullness, nausea, vomiting with it. Yeah. Hold that thought. We're going to talk about the GI stuff later today, so hold that thought. Yes. So you want to give it oral? Do you want to give it rectal? Do you want to give it IV? Subcutaneous, IM? You have to think about the different routes you want to give, and sometimes rectal is the quickest absorbed in the ICU. You don't have to worry about expensive IVs and things to do it that way. It's kind of old school, but it does work very well. Phenergan suppositories. If somebody can't, if they're vomiting, obviously they can't take oral, right? They're going to puke it right up. So rectal is great. And then you write that PR. If you've never written that before, PR means per rectum. Question?
Oh, he said sublingual, and then you went rectal. I was like, sure.
So, while we're on the GI, what else do you want to talk about GI-wise? Besides nausea, vomiting. Laxatives, stool softeners. What kind of medications back people up that you need to compensate with stool softeners?
Zofran.
What cardiac medicine?
Oh.
Not beta blockers so much, but calcium channel blockers really can back people up. That's one of them. Opioids. All your pain meds that you're going to be writing, that really backs people up. But people have GI conditions, diabetes itself, gastroparesis slows up the GI tract. That's why Reglan's awesome. Metoclopramide is really good to help move things along there. But there are certain medicines, I think about calcium channel blockers and opioids probably most commonly. And even when they're going home, if they're going to go home on either of those two, I'm going to write a stool softener of some sort to help that. So what else? What else besides constipation? So you hit the nausea, vomiting, you hit constipation, but there's one other class of drugs for the GI system to know.
Antidiarrheals?
Yeah, you're protective, right? Your H2 blockers or your PPIs, if they need them. If they're on Plavix, and maybe they're on steroids or something else that's going to be thinning up their gastric mucosa, we're worried about ulcers. Maybe they're undergoing treatment for H. pylori. They already have a deficit in their tract. So you have to protect their gut. Stress. Patients are not eating like they normally do. They're NPO. They're not feeling hungry because they had these big operations for whatever, their appendix, their belly's bloated due to air post-operatively. They're not very hungry, so they're not getting the food in there. And the gut starts to thin up the mucosa, and you can get more ulcerations and bleeding ulcers. So you need to protect it, whether it's H2 blockers. You heard Dr. Smith talk last time. I heard about the S word that I never could say word, the sulfurate or whatever. Yeah, that one. It's an old school one, but we use it in the ICU and it works great. The old time docs love it because it helps coat the gut and it helps protect it. But usually, mostly we're thinking about H2 blockers and PPIs for the most part to protect their gut if they need it, not for every patient. It's always a case-by-case basis. All right, so you hit a lot of the GI stuff. You hit all the A's, antibiotics, analgesics, things like that, and stuff. What else? Chemical restraints. So he's going right to Haldol. He's just dating all his patients if needed. Yeah, but if you get agitation of patients, I usually don't write that as a routine order post-operatively. You can give something for a touch of anxiety here or there, maybe a little benzo, in the hospital. But I don't usually write for Haldol unless you get called for those types of complaints and you write that. But I'm just talking about a general order set of insulin. So we're going to talk about the glucose stuff, right? So what do you think about glucose? So normal patients, do they need insulin post-operatively? No. Do they need anything for glucose?
Well, it's low.
Parenteral nutrition, they do get it, I heard.
D5.
What do you think? D5, you give them D5, so you give them a little sugar if they need in their fluid. The bottom line is, post-operatively, you do have to cover yourself in case they have hyperglycemia. Because even patients who are normal like you or I can have stress reactions and your sugar goes up pretty high. And this is a big, big thing nowadays as compared to 30 years ago that we're on. And I'm going to teach you right now something that please don't ever tell Professor Lay because she wouldn't like to hear it, but it's the one surgical sliding scale that we've used for decades and decades and decades. And yes, diabetic educators would, oh my gosh, it's too much or it's too little or whatever. But the poor man's way, if you can remember nothing else for a patient at all, the way that I remembered it was basically you write a sliding scale, 150 to 200, 201 to 250, 251 to 300, 301 to 350, sometimes we would, this is the way that I've written this, I'm not joking, probably 500 times in my life, okay, and I've never, ever, ever run into a problem with it. Where you start by 50, so it's an easy way to remember. So you start at 150, 200, 201 to 250, 251 to 300, 301 to 350, and anything higher than 350 or that, call. And it's just units of 5, 10, 15, 20, right? Okay, 5, 10, 15, 20 units of regular insulin, all right, just to cover it. So sorry, but I was thinking that we've done some other things, but this is the easy way to remember. Just go by 50, starting at 150, up a little bit. 5, 10, 15, 20. Some people would decrease, they would start at, there's different ways to do it. You can start maybe, if you want to be less aggressive, you'd start here, 5, 10, 15, 20. If you did 350 to 400, and then I've seen people do over 400 call here. And if they do 150 to 200, they might just be nice and do 2 units up here. So there's different ways that you can write it, and there's no black or white. Whatever works for you. This is just one of the ways. Starting at 150, if you want to be a little less aggressive, and just give them 2 units. But sliding scales, there's all these protocols that are out nowadays. There's consult services you can do, diabetic educators to come in and help this. ICUs have their own protocols with it. But thinking about the glucose in patients, even in a normal patient, is something that you want to think about and write a sliding scale for even the normal patient. So glucose, yes. If they need insulin, then you're going to be more specific and write down any insulins that they need. Usually a endocrinology consult if you're not that service. What else? What other medications do you think the patient might need? So you've hit nearly all the big ones and all the systems that you've gone through there. Other medications associated with that procedure or with that body system. So what I mean, if it was a cardiac patient who, let's say, is found to have a low ejection fraction, then you want to maybe start thinking about some of the additional beta blockade or ACE inhibitors if they can stand it. If it's a diabetic patient, ACE inhibitors post-operatively, at what point are you going to start it? ACE inhibitors are good for all diabetic patients, but sometimes in the early phase, when they've been stressed, when their body has undergone a big operation, or their creatinine is starting to go up a little bit, that's a bad time to start ACE inhibitors. We don't start ACE inhibitors until we notice that creatinine is coming down. So you may need to wait a day or 2 in the hospital before ACE inhibitors. It's not a solid rule for every single patient, even though they're diabetic. We want it at the time of discharge. Maybe you find out that with coronary artery disease, they're coming in for CABG, they've never been on a statin. Guess what? Post-operatively, you're going to be writing for statins on all of these patients. They're in that high-risk category now, and for the rest of their life, that's one of the mandatory medicines they're going to take. How about diuresis, diuretics? A lot of patients, they don't need them for certain procedures, but the critical ones, the trauma patients, maybe you want to affect, some of that, the I's and O's, their weight's going up. They have more I's than O's on a daily progress note. So now you need to fine tune them a little bit. How much Lasix do you write if you're going to write for some Lasix? 40, 20. It's patient by patient. If a patient has never had diuretics before in their life, 10 milligrams of Lasix may be all that they need. 20, not bad. 20 BID we often do. We start at a dose of 10 or 20, and then we'll modify from there. If they need more, then maybe the next day we'll go up to 40, and we try to give it IV. You can give it PO. So these are different routes you have to think about. What should you be writing for if you write for if you write for Lasix, furosemide, potassium, right? So technically, if you write for 40 of Lasix, you should be writing half the amount, 20 milliequivalents of potassium at that same time, as long as they don't have ACE inhibitors or renal dysfunction or digoxin, or you do check their potassium to make sure what it is. So that's something that goes hand in hand with that. So diuresis you think about also. Anything else, Dr. Smith, that you think we covered basically all? And then the last one is labs. And labs, you have to be specific. Back in the day, it was all standard. They got labs every day when they were in the hospital. And hospitals have really kind of crunched down on this to make sure you're not getting labs when you don't need them. So you have to be specific. Post-operatively, you may only want a hemoglobin and hematocrit. You don't need the full CBC on admissions, just to double check the hemoglobin and hematocrit. Or maybe you do want the CBC right away, and you write that. Electrolytes are pretty standard, always for post-operative. And then each day, you're gonna see how much you want. Sometimes people say, I remember my first job, we only did labs on post-op day number 3. We did chest x-ray and post-op labs on day number 3, and that was basically it. Other hospitals, Mayo, we did them every single day on the patient. We would fine-tune them as we went, but they wanted more of that data to keep up on the patients a little bit more. So it can vary what you want, but you have to think about your chemistries, your hematologies. Do they need blood possibly? You're gonna do your type in screen versus type in cross. You saw that in the notes from Dr. Smith and myself in lab medicine. And then any of your other special tests from time to time. What if a patient is bleeding and they have hemolysis? So they have a hemolytic anemia. All the red blood cells are being destroyed. What kind of labs might you want to add for a patient who has a hemolytic anemia? Blood smear, what are you looking for on the blood smear? Just the size? Okay. Good one. How is that going to help you? Okay. What else? If you're destroying the red blood cells, what is being leaked out from inside them?
You're checking.
Potassium, yeah, that's one thing. Yeah, there's more potassium inside the cells than out.
Bilirubin.
What else? Bilirubin, right? So your bilirubin levels. What else? What? What'd you say? LDH is technically one of them. You got the L of the lactic, right? So lactate dehydrogenase. That is that's like a test question thing, but no one ever does it in the real world unless you deal with lots of hemolysis issues. Because there's more LDH2 that's inside the cells, and now there's 5 different subtypes. Don't worry about that. But LDH is one of them. But there's also another lab I want you to focus on. I mentioned it in CLM, and it's called haptoglobin. Haptoglobin. What is haptoglobin? Haptoglobin is a protein that will try to absorb any of the free radical bilirubin that's out there that's being destroyed. Haptoglobin. So you only think of it that you only have 100 molecules of haptoglobin in your body. Bear with me for a second. You all have 100 molecules of haptoglobin in your body. If you have hemolysis, that haptoglobin is going to be all working, right? It's all being attached to the free bilirubin that's out there. So do you think your serum haptoglobin levels will be high or low? Low, because they're all being used up, right? The haptoglobin that's being measured in the lab is technically only measuring the free haptoglobin, not the bound haptoglobin. So that's why it's decreased. People are like, wait a minute, it should be increased because it's trying to know. You only have so much in your body, and they're measuring the free aspects of that. So hemolytic anemia, some of the labs, LDH, haptoglobin, your bilirubin. What else? Maybe you want LFTs on the patient. Maybe you want some endocrine things, TSH. Your renal, part of your basic electrolyte, BMP profile. CMP gives you a little bit more, usually your albumin level with that. Usually an ALT or an AST is part of that also, and even a total protein or calcium. Calcium becomes important. We talked about calcium or ionized calcium in CLM. So different things you may want to think about. The magnesium, cardiac patients, magnesium, GI, ileus, we talked about that. Getting magnesium can be helpful in those patients, checking a mag level. And if you're writing nutrition, you all had a nutrition class. If you were to give TPN, what kind of things would they look at to adjust on a daily basis? TPN, well, albumin, yeah, but they're going to be looking at the magnesium, the phosphorus, the calcium. They're looking at all that. They're going to modify it as needed. So all the labs are going to be important for what you need. So different sets of orders, but it's all the same thing, ADC Van Dismal. You're just writing what you need for that patient. Okay, your notes. Different notes that you're going to be writing in the hospital. Now, we've already talked about the H&P, history and physical exam. That's your bread and butter to get the patient into the hospital for medical or surgical reasons. Notes are very short paragraphs for the most part. An admission note. If your attending that you work with after you've done your H&P, comes by to see the patient for a quick visit. Hi, how you doing? We're gonna do surgery tomorrow morning. They may write a very short note. 67-year-old patient, admitted for pneumonia, planned for VATS procedure with decortication tomorrow for empyema. Very short, admission order is written, that kind of a thing, very short. Consult note. So maybe the patient's in the hospital and now you are gonna consult, whether it's the endocrinology service or infectious disease service. You may be the PA who's working on that service, and then you have to see the patient, and you're gonna write a consult note. You're gonna write basically what you got consulted for, what you found, what your plan is, basically like a SOAP note for that, but it's specific to your specialty of what you do. Operative note, we're gonna talk about that in just a second in the next slide. Procedure note, any procedure that you do, and you'll be doing many of these in the hospital, whether it's a lumbar puncture or wound vac change or whatever it is, you're gonna have to write a note, and I'll show you that also. But the bread and butter of what we do as PAs is write the daily note, which is either an ICU note or a progress note, which is a little bit shorter. So the progress note is your SOAP note, S-O-A-P. Obviously, you're gonna put the dates of when you're there. You're gonna say why they're there. Maybe it's post-op day number 1, status post-appendectomy. And then you're gonna do your SOAP. S is subjective, what they tell you. I always ask, how are you feeling? Do you have any complaints? Very short, I'll say, feeling well, no complaints. Right, that's what they told you. Objective, you always start out with your vital signs. So you're gonna do your 2 vital signs, 2 aspects of each of the 6 vital signs. I want you to possibly think about the daily weights, if it's that part of it also. And then you'll get into your different systems, your AG&T, cardiac, lung, abdomen, incision, wound, neurologic. Very short and sweet, usually only 5 or 6 areas that you're gonna focus on for the objective part. Then you put any labs for that day of the patient. So after you do your objective of the body systems, you always put your labs. Labs are part of objective material. And then you have your A and P, your assessment and your plan. So your assessment could be, number 1, status post, post-op day number 3, status post-appendectomy. And number 2, maybe there's some post-operative anemia. If you found a hemoglobin of 8.2 or so, any positive findings on that patient post-operatively that are new in the hospital that are going on. Maybe anything, it's sort of wound care, or maybe there's drainage or decreased urine output, or any new things that are going on that you want to address. It's the assessment. And the SOAP note is not the time to write 20 different things of they have diabetes, they have history of a grandmother who died. This is a hospital note of what's most important from that operation, or on a daily basis of what's going on with that. Question? Yeah.
One comment is, all of the billing, so, you're doing this and it's a surgeon, like annotates and it says, now, there's been a lot of changes since the last year, so one thing is, you will be asked probably by most people who know what they're doing to try to get paid, if your services are there, to do a quick review of systems. So if you go in and they're gonna charge at the lowest level of a hospital policy,
those of you who have been going to the nursing home, at least with me, I tried to flip to the back of the paper chart that they have, and you'll see the progress notes, the daily progress notes from when they were in the hospital before they came to the nursing home for the rehab that they're coming in. So that's basically the SOAP note, and sometimes they're extremely short if they're by a consultant. You know, if it's an orthopedist that comes by, they may write like literally 3 lines. What I don't want you to do is write, you know, VSS, AF, vital signs stable, afebrile, those types of things, because you're going to see that. But our job as a PA student and as PA is to provide more information and more concrete information, because heaven forbid you ever do get called into court and your note will be blown up there for everyone to see, and it'll say vital signs stable. You wrote vital signs stable, Mr. Nicholas Casal there, and but yet the patient had a fever of 102.6 and the heart rate was 58 that morning. And why did you say it was stable and you chose not to do anything about that? So what happens is you're better off to say, you know, heart rate 76 is regular, blood pressure 142/86. Just be more specific rather than less. That way you're covered, and it shows that you wrote it, you looked at it, and you look for any abnormalities in your own SOAP note. It's a double check system. Then you can use that as part of your plan to fine tune it. So assessment is going to be the main issues of what they're there for and any problems since the operation. And the plan is what you're doing for the patient that day. And it may only be 2 or 3 small things. It may be increased beta blockers. Sounds silly, but you know that's what you're going to be doing, and you write an order of increased metoprolol from 25 BID to 50 BID. That's something you actually did. It may be increased diet. It may be increased activities. I'm thinking of really simple things. We can't remember anything else of the patient to write down. Increased activity, increased diet, add medications, pain control, DC chest tubes, increase incentive spirometry, endocrine consult for sugar, 350. It's the plan. It's the nuts and bolts of what you've done for that day. And after you've done these for each day, and if you've done a good job, when you have to do the discharge summary, you only have to look at your notes for the day, because if you looked at the other consultant notes and you added 1 line of what they mainly did, you can quickly do a discharge summary just by flipping through that chart or in the computer system to look at. The more you put in your note, the better it's going to be. The ICU note is more complicated in a really sick, critical patient. So I'll give you probably the worst ones, the cardiac surgery, if any of you are going to go into that. You can imagine a patient just had open heart surgery, they have chest tube coming out, they have pacing wires coming out, and maybe they're being paced at this time. They have a Swan-Ganz catheter, which is in the pulmonary artery, measuring all the cardiac index and all the RA pressure and all the other different numbers that we'll talk about in ICU. They are sedated, they're intubated, they have a NG suction, they have a Foley catheter in them. Maybe they have a wound vac on their sternum also from the OR. So everything has to be documented. It's kind of like a SOAP note on steroids. So you can get away with a shorter SOAP note on a normal basic patient, but generally 1 page at a minimum for an ICU note. And you're writing more in the subjective is usually easy, right? Intubated, sedated. That's all you have to write is 2 words and you're done there. But the objective, you're going to write down all the vital signs, but you're going to write out more of the numbers. You're going to write out, cardiac index was, 2.5 maybe. Or you're going to write out urine output is, usually what we do is 2 numbers. We'll write how much you've had out in the past 8 hours and then the past 24 hours. So I like to write out your urine output. It's kind of a number for the last 8 hours and then the last 24 hours. I's and O's, the total number for the last 24 hours. So how much have they had in total I's, how much have they had out? Chest tube drainage, same thing. I'll write how much they've had out in the past 8 hours versus the past 24 hours. So if somebody sees that, they'll know, okay, they dumped a lot here, but over the past 24 hours they haven't had much, it's just 1 dump. It tells more of a story when you see that. The daily weight, the admission weight. Sometimes people like to write weights as 3 numbers. They'll write the current weight, they'll do yesterday's weight, and then they'll do the admission weight. So you have three numbers to compare it to: today's weight, yesterday's weight, and then the admission weight. That's kind of important to know. So if you're diuresing the patient, if you want to fine-tune numbers, how close am I getting to that pre-op weight? Question?
Okay, so when you're doing output, is that what you're saying?
I do a total I's and O's, and then I'll do one for urine output, and I'll do one for like chest tube drainage. But that's basically the big stuff. To me, that's the big three: the total I's and O's, and then I'll do urine output, is probably the next most important one, and chest tube drainage would be the three things that I will kind of separate out for that. But the daily weights is important as well. Oxygen percentage. So when you write they're on the ventilator, you want to write, basically how much oxygen they're getting. Are they getting 100%? We'll talk about that in the ICU, not right now, but how much they're getting is kind of important. So you can see you're going to progress, you're going to wean the ventilator. That may be one of the plans. After you do all your vitals objectives, you're going to do more of a complete head to toe system, with including more things. It may include things of nutritional status that you're giving, either their TPN or tube feeds that they're getting in GI, any kind of wound care and antibiotics and cardiac and pulmonary, they're on the ventilator. So it's more specific from head to toe, including neurologic status, including basically more systems. So note, you can get away with 4 or 5 systems to do: heart, lungs, abdomen, skin, for wound, and maybe neurologic would be the minimum there. But for the ICU, you're nearly going to hit every single system with that. And Dr. Smith will go over some of that also when she does trauma. So I'm not going to get into that. Just know the ICU is more of a complete. Some people in the margin, they will write how much time they spend with the patient, which is important for billing purposes. So you may say 30 minutes. You may say 45 minutes. You'll see in the margin. You may see 60 minutes in the margin. And that's how long it takes for you to see the patient, to look at all the labs, to make your plan, and your plan and write the orders. So you'll see that sometimes. I want to talk about post-operative days. This is something that Dr. Smith and I have a mutual friend who works at Mayo Clinic. And Mayo Clinic is the exception to this rule, but I'll tell you, 99% of the world, when you talk about post-operative days, if your uncle is going into surgery right now for his appendix, okay? What's today's date? The 25th? 20th. So it's the 20th. Today, for him, is considered post-op day number 0. POD number 0. So he undergoes a quick procedure, he goes to the recovery room, and at 4 o'clock, you decide to round on him, see how he's doing, you write your note, write some post-op orders, some transfer orders. You would write in your progress note, post-op day number 0, today, the day of the actual procedure. Tomorrow, as of tomorrow morning, or midnight technically, would be post-op day number 1. Tomorrow would be post-op day number 1. And then you follow from that way, post-op day number 2, 3, 4, 5. Sometimes it's post-op day number 76. I kid you not, in the hospital, people kind of forget, and they forget to write that stuff after a while, but you can calculate it back if you need it.
So the midnight after surgery makes it day 1. So
Changes
if
it over.
Like a late surgery, like 8 p.m. surgery, that midnight makes it.
Yeah, if someone has an operation and they get transferred and they're done at 11:30 at night, technically that was post-op day number 0. We don't say 24 hours, so you're not always calculating, from the time of the operation. We just round it up to that midnight and afterwards. But what I'm saying is, if you were to write a note today on the same patient, technically that would be post-op day number 0, and tomorrow would be post-op day number 1 when you come in the morning and see the patient. But technically midnight, to make it simple for the world. And that's 99.9% of the world. Mayo Clinic, for whatever reason, at least in Rochester, Minnesota, they went against the grain, and they would always say that the day of the operation was post-op day number 1, and then we'd have to add a day, which it was always messed up in the world. But this is what I want you to know is the day of the surgery is post-op day number 0. That's what you're gonna see in 99% of the world there. So for all your notes. Okay, the operative note is I think pretty simple, and you've done the hard part. You've done the actual procedure aspect. Well, let me explain. There's the operative note and there's the operative report. The operative note is a short note that you write in the chart after the operation, which includes these things here. Obviously the date and the time, the PPP, the pre-op diagnosis, the post-op diagnosis, which is usually always the same 99% of the time, unless they find something new in the operation that they fix, that they then are going to put in there. The actual procedure itself of what was done, and I'll give you an example of this in a moment. Who the surgeon was, who the assistant was, you, who the anesthesiologist was, or CRNA, EBL, estimated blood loss, findings. You don't always have to put findings, but if something was unique or relevant to the case, you could add a small little note in here about that, but usually we don't. Any tubes or wires, that becomes important. That's very important because you may be the only person who can at that moment you saw what they had. They had 3 chest tubes, right? Well, try to be a little more specific. They had 1 right pleural tube, they had 1 mediastinal tube, and they had or 1 anterior mediastinal tube and 1 posterior mediastinal tube and 1 left pleural tube. So you're trying to be a little more specific so you know what those tubes are. Sometimes they label them, sometimes they don't. Most of the time they don't, I'll be honest with you. But you, who was in that operation, who put the tubes in with the surgeon, you know where they actually physically are. And that may be the only place sometimes in the whole chart that they go to find that info. If you're pulling the tubes 3 days later, and you're trying to say, where are they? You get a chest x-ray, and you got to try to figure out just to be safe, because the surgeon will say, well, pull the anterior mediastinal tube. On rounds, you're walking around, and they say, pull the anterior mediastinal tube. Okay? And then an hour later, you go to pull it, and you see 3 tubes on that patient. You're like, uh-oh, which one's the anterior? And you don't want to pull the wrong one, because they wanted one specific one there. So going back to it, sometimes they're labeled there. And if you are the person giving the note, that's going to be important. So where the tubes are, any wires. Wires for chest cases, sometimes we have atrial wires on the heart. Sometimes we have ventricular wires on the heart. What I mean is they're literally these tiny wires that will suture in with a Prolene, but they're loosely sutured in. So if you pull on that wire, it'll slide through the suture and it'll come out of the patient. So they're loosely sutured in on either the atrium or the ventricle. And we do that to pace the patient if they need it after surgery. Cardiac cases, generally speaking, we always put both AV wires in the top ones, the atrial ones, and the ventricular ones. And they will be often paced afterwards. So heart rates are slow. We'll purposely pace them at 70 to 80 beats per minute, or maybe even 100 afterwards, post-operatively. And then you'll just modify it each day. Any complications of the case, which hopefully are none, and you're just writing, none from there, and then you have to sign it with your legal name at the end there. So this is a real easy thing to do. It's very short, very sweet. The operative report is similar to this, but it includes that dictation of the procedure that they actually had. I gotta ask, so many of you guys are laughing, you're on Google or what? What's so funny? I see so many of you guys going around. There's something going around now? I see all your smiles around here, so I'm laughing. What's going on? Anything? All right, okay. So the operative report is very similar to the op note, but it's dictated by the surgeon to include that long procedure section that you saw, as well as usually a indication and history, physical exam, a little paragraph of that information in there. The procedure note has a procedure name, indications, consent, anesthesia, the procedure that's explained if you're doing a lumbar puncture, etc. with it, and any findings that were unique to that procedure. Discharge summary. This is going to be very important. The components of this, you're going to be doing many of them. Most of the time they will be dictated. Sometimes they will be written out depending on where you are in different institutions. But the components of them are listed here in the next couple slides. Obviously, the date of admission of the patient into the hospital, the date of discharge, the admitting diagnosis of the patient, which is not just one word, like we talked about earlier today, but this is a list of the things that they came into with the hospital. Maybe they do have, the main problem they have is shortness of breath, suspect pneumonia, rule out pneumonia, something like that. It's the #1 diagnosis. But then they may have type 2 diabetes and hypertension and medications that they're on, why they're on, what the reasons they're on those for, what there will be listed as all the admitting diagnoses. Discharge diagnoses will be what was the main thing they had in the hospital. So maybe they underwent open heart surgery, CABG ×3. So you'd say severe coronary artery disease, status post CABG ×3. That's the main discharge summary of what they were there. And then you can literally cut and paste all the other admitting diagnoses as part of the discharge diagnoses under there. I like to see more rather than less. Some hospitals may say you only need a small amount. I like to say more. But basically anything that happened in the hospital. So maybe they did have post-operative anemia requiring transfusions. That would be a discharge diagnosis. Maybe they had hyperglycemia requiring endocrinology consults. That would be a discharge diagnosis that you need to be aware of. So anything that occurred to that patient in the hospital will undergo the discharge diagnosis starting at the top, working your way down.
Do you not include any in the tests that you've run or?
Yep, we're getting there. Then you get into, hold that thought, so it's on the next slide. Medications. Medications may be at the beginning, medications may be at the end, but they have to be in there. And this is the vein of our existence nowadays, because we have to reconcile all their meds. A lot different than it used to be 30 years ago. So you have to write in what the medicines they had coming into the hospital. If somebody did a very good H&P, all you have to do is say, cut and paste the admitting medications from the H&P on this date. And you're covered for that. Real easy thing to do at dictation, as long as it's a good, that's why PAs are pretty good at always documenting that stuff. The discharge medications, you're gonna be spending a lot of time making sure you cross your T's and dot your I's with these meds to make sure you've covered everything that they need to be on, as well as everything that they were put on in the hospital. So maybe you're gonna give them some pain meds, some Percocets for how many and for how long, right? Or maybe it's gonna be some H2 blockers for how many and how long, or cardiac meds, or aspirin, or statins, or specifically spelled Lasix. Sometimes we give patients a week of 2 weeks of Lasix for a little bit, and then we'll see them in the clinic afterwards, and we'll fine tune that. Maybe we'll keep on some antibiotics for a certain number of days. Again, just like we talked about, the name of the medicine, generic, the dose, the route, how long they're gonna be taking it for all of that. Then the attending physician must be on there as well. There's gotta be one person who is in charge. If it's a surgeon that they're coming in for an appendectomy, then they accepted that patient, that may be it. Or maybe they came in on the medicine service, and then the medical doctor will still remain as the attending physician, and any consulting physicians will be listed in a separate category. The endocrinologist, the surgeon, the infectious disease doc. There's always one person on each team that is the MD's name, not the PA's name, but it's gotta be the MD that you had. Sometimes the MD doesn't always walk by, they put a little scribble, and you gotta figure out who that was on one of their dictations to put their names on there. Procedures. This is where you're gonna list any procedures that they came into the hospital. So somebody, let's say, comes in with chest pain, they come into the ER, they found to have myocardial infarction, they go to the cath lab, they undergo coronary angiography, it's decided that they need to have open heart surgery, then they get an echocardiogram to make sure their valves are okay afterwards. The next day they go for open heart surgery, and post-operatively they ended up needing a pacemaker as well. 2 days later they get a pacemaker in the hospital. So you gotta write down all the procedures. You gotta write down, cardiac cath lab, coronary angiography, the date, and whatever the findings were, the main findings of that procedure, as well as your CABG the very next day. And then you just look at those op notes to go back in the chart to see what it was, and you write that in there. And same thing for the pacemaker, that it's gotta be the date of the procedure, who did the procedure, the surgeon or the physician, and any complications or findings of that procedure. Very short and sweet, usually just 2 lines. You don't have to go into much depth, but they wanna know the specifics of that there. The HPI, if someone did a good HPI on the H&P, just cut and paste the HPI. You don't have to do the whole history and physical, cut just the HPI portion, which is nice. The hospital course. This is something that you'll all get good at with time, where you literally, if it's a paper chart, you would flip through the paper chart and you're telling the story of patient came into the hospital through the emergency department with chest pain, was found to have an ST elevation myocardial infarction, was admitted, cardiology was consulted, who came and saw the patient and took the patient to the cardiac cath lab. While in the cath lab, patient was found to have 4-vessel coronary artery disease, and cardiothoracic surgery was consulted for emergent intervention. Cardiac surgery evaluated the patient, and after echocardiogram was found to have 2+ aortic regurgitation. The next day, our patient was stabilized over the night in the CCU on 8/23/2017. Patient went to the operating room, underwent CABG ×4. On post-op day number 1, patient was extubated, and drips were weaned, inotropes were discontinued. Later that day, patient was transferred to the floor. During the hospital stay, nutrition was increased, activity was increased, beta blockers, statins, aspirin were initiated. Chest tubes were discontinued on post-op day number 3. Patient was transfused 2 units of packed red cells for hemoglobin of 7.2 on post-operative day number 4. On post-op day number 5, patient was doing well without complaints and was discharged home in stable condition. Basically, that's a very quick summary of what happened during the hospital, the main points that you're trying to hit on, any issues that occurred. That's the big paragraph that you would be dictating or typing up for that. And finally, disposition condition of discharge has to be there. So, and I said that as the last line, patient was discharged home in stable condition. So that could be a separate line, or that could be part of the last line of the actual paragraph of the hospital course, but it must be in that note. And finally, any discharge instructions. So this is going to be important. This is what the patients, that's all they're going to focus on. They're going to say, okay, I have to follow up with Dr. Smith in 6 days, right? And that appointment was made in the hospital by the nurses. It's going to include changing maybe wound dressings every 48 hours over the next week until seen in the clinic, right? It's going to be check glucoses as per endocrinology, 3 times a day, and call the nurse educator, diabetic nurse educator, if numbers are higher or lower than this, whatever the specifics are for that patient. Maybe a patient's going to go home with a Blake drain, and they have to record how much drainage or anything, wound care, special things that patients that their family members will need to know. Because they're not going to understand medicine, but they're going to understand the discharge instructions because it has to be written out for the lay person there. So long story short, for your surgical oscillor, not only will you be spending an hour in the room evaluating a patient, as that list I gave you on day 1, hopefully your class is already starting to break up all of those 20 topics to make it easier for you. If you haven't done so, I really recommend you start doing that, because it will become overwhelming if you haven't done that as it gets closer to that week to know those 20 topics very well. And for your write-up will then include the admission H&P, admitting orders for the patient into the hospital, the actual operative note, which is very short, the post-op orders, your ICU note of the patient, your transfer orders from the ICU, ADC Van Dismal again, going to the floor, a very short, 3-day progress note for that patient, and then the actual discharge summary for that patient. The good news is you will get to work as a team of 2 as part of that, so you get to divide up some of this work, so you're not all doing all of it, you're only doing 50% of it, and you'll have a certain amount of time to hand it in, at least 1 week. I'll look at the schedule and I'll see what your test exams are, and if I need to extend it, I'll come up with a specific time, I'll let you know, but you'll have at least 1 week to do this on your own to hand that in as part of the grade. Question? No, it's a snapshot of time. You're only doing at what they came in on and what they're going home on. You don't have to talk about, now, in the actual note that I think that I just talked to you about, like the hospital course, if you want to say like, oh, ACE inhibitors were initiated, but then were discontinued because increase in creatinine, that's where you would actually say that. It would be right here in that. You don't have to put any specifics. It's just a snapshot of what they came in with and what they go out with. So that's what people really care about. If you were, let's say, going to see the patient 2 weeks later, I don't know, you're working endocrinology, now you're seeing the patient for the first time, you want the hospital discharge summary, and you're going to be looking at those discharge medications to know exactly what they were on at that point. Because patients are not going to remember all that stuff. Any questions? Any questions on this stuff? It's a lot, for sure. For the actual PDF, that big PDF that I told you, what I want you to know, only a couple things. Page number 1 of the admission. Page number 1, which is page number 143. The next section I really want you to look at is the admitting orders, and I really went through all of that today. I think you should read that. It's called Admit Orders, which is on page 148. It's broken up into a couple pages, but it's a very light read overall. And the next section will be the discharge. If you need help with that discharge summary, it will be the discharge summary, which is on 191. Page 191 to help you there. Everything else, I expect that you likely look at it, but don't spend too much time on that. This is what we do every day. You may not have talked about this for the last 9 months, but you talk to your bigs right now, and this is what you have to do. It's the flow of patient care, and it's the documentation of flow of patient care, which is really, if you want to be the best PA possible, this stuff is what you need to get good at, because your surgeons, your attendings, the consultants, they love having us because we spend more time with this, which makes their job a lot easier for the documentation part of it. When Dr. Smith, if I worked with her and she came and I saw the patient in the morning, I did my rounds, I wrote my progress note, I wrote my orders of what I thought. She comes by, she sees the patient, she can see my notes, she quickly looks at any objective findings as well. She may add one thing, or she may just say, she may just sign the note. That's it. And that's the goal, is to make their jobs easier to help. And they know that we're working, we understand the patient from beginning to end. And that's kind of important in the big scheme of things. Because a lot of times you just work a weekend here or there, you work every 4th day or that, you come in, you don't know these patients for 3 days. The PA who gives you a report tells you about it, and now you got to figure out everything, and if you have a good system of notes, that will help all of you there. Any questions? Any questions on anything so far? All right, take a 10-minute break. We'll get started at 10 o'clock.